Welcome everyone to today's webinar. I am Emma Goodman with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. We are pleased to have Karen Landon, Director of Healthcare Solutions Marketing at Nuance, here to moderate today's question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the recording and additional white paper assets to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Jeremiah Rothschild is the Senior Director of Strategy for Nuance's Provider Solutions line of business. His background spans more than 13 years of experience working across public and private sectors, advising providers, health plans, PBMs, life science manufacturers, retail pharmacy, and governments on growth and transformation. At Nuance, he focuses on the application of artificial intelligence to streamline clinical and administrative functions. These innovations amplify human intelligence to support quality of care, reduce physician burnout, and enable full reimbursement. Jeremiah recently led an initiative to bring to market the first AI-powered in-workflow quality and risk adjustment solution to support value-based care, which will be the subject of today's discussion. Jeremiah has spent his career innovating in healthcare, building practical solutions that matter. At McKesson, he led growth initiatives for both Relay Health, medical, and pharmacy claims processing. Before that, he held leadership roles in strategy at leading consultancies, including Gartner, CSC, and IBM. Jeremiah has filed patents on a range of innovations to streamline administrative aspects of care in the pharmacy and the provider setting. Jeremiah received his master's degree in medical informatics from Northwestern University and his bachelor's degree in economics from the University of Maryland, College Park. Jeremiah, it's now my pleasure to turn the floor over to you.
Thank you, Emma. I appreciate you facilitating this today and appreciate the collaboration as well with Karen Landon and everybody else that's put this together in the background. This is a really exciting time for us as we're looking at healthcare and looking at the transition that's going on. What we're going to be discussing today really is making the case for new approaches for quality and risk adjustment, really focusing on the ambulatory setting, and really the importance of intelligence and automation to enable this. What's really neat about the ambulatory setting is that just given the volume and the throughput and the variation in care provided, there are needs for unique approaches for how care is delivered and how members and patients are interacted with to be able to affect the best outcomes. So we're really going to look at it as we dive in today to the clinical documentation risk adjustment practices in the ambulatory setting, how that is evolving, and why you can't just take what you're doing perhaps in the inpatient setting and transplant those into the ambulatory setting. There's some unique differences between the care settings that are important to recognize to build a scalable program that drives value. And that's where automation really comes in to improve the clinical documentation, but really start from an interventional standpoint, progress to the clinical documentation to drive better care, higher physician satisfaction, and really enable it at the point of care when you have the patient there, that you have the maximum opportunity to affect the end result of better care and better satisfaction with the overall experience. So that's what we're going to be discussing today. Please feel free to send questions in, and Karen will be monitoring the line for those questions, and I'll be happy to answer those as we move through the presentation at the end. One of the things that's neat as we look at the industry challenges, just as a look back over the last several years, is that as I grew up in revenue cycle, one of the things we saw was, early on it was about the eligibility, the verification process, making sure that on the front end side that you got the information in so that you could bill on the back end, and then you'd work your denials to maximize your reimbursement for what's allowable. As the industry is shifting, though, we have really what's gone from what I would call a gradual tilt to a slight acceleration on the journey to value-based care, where in the initial years we have bonus and penalties, and for most organizations it's been historically trying to avoid the penalties and where possible get the bonuses. But now with capitation, some of the changes, it's really driving more to a greater value orientation over a gradual rollout. As we look at MACRA and MIPS and the implications of risk and quality and the shifts even between the different categories, it's becoming important to think about more holistically what that means to a provider business as we talk to clients. As part of the work that we did to come up with our solution, we actually interviewed well over 100 clients over the last year and a half, from CFOs, CEOs, heads of revenue cycle, population health, physician leadership, from large organizations all the way down to small organizations to understand needs. And one of the common themes that came out was, with all the changes focused on revenue integrity and providing care, it's become an alphabet soup of programs, some federally mandated or state mandated or payer mandated, and some by the organization. And those programs don't always tie together nicely, and it creates a situation where burnout is high for physicians and other members of the care team. And so that's been identified as part of the work that we've done as a significant challenge. So as we look at moving from the first phase of the historical to where we're living today, to where we need to evolve as an industry, it's really about achieving optimal care and reimbursement, moving beyond meaningful use and PQRS, which, although still important under MIPS and MACRA, it's really more about how do we create real value, how do we close gaps in care and do it in real time to minimize the work effort on the individuals involved, while also balancing the end result needed of affecting, in many cases, behavioral changes with the patients or targeted interventions. So as we're looking at this and framing up how we were thinking about going to market with the solution, it was really about solving the key physician, patient, and member-related issues that affect the different stakeholders in the coordination of care with the care team. So in terms of doing this, really the key capabilities that we found through our research was there needs to be a way of being able to identify the key patients and the interventions required by really being able to sift through the patient population. Do it in an automated manner using population health tools to be able to know where to focus. Because with limited resources, and when you look at typical reimbursement in the ambulatory setting of $90 reimbursement per encounter, on average from the industry surveys we've done, about 7 to 8% reimbursement. You're talking about $7 and change per encounter is when you factor in all of the variables, but what you typically make. So when you're thinking about the high volumes in the ambulatory setting and the care needed, the focus needs to be there to target the right patients. Now, when we think about that, one of the key things to consider is, what is a right patient? You have patients that have chronic conditions that certainly take up a substantial portion of the overall spend for provider organizations having to manage a patient population where they're bearing risk. But there's also patients that may be on a cusp of becoming part of a higher risk group because of characteristics, whether it's socioeconomic, behavioral, or just frankly their lab values and how they're maybe borderline diabetic, but they're not quite there yet, so they're not medicated. How do you keep those folks from rolling over and becoming a higher cost group? So really having those analytics in there to be able to sift through and find the patient is really, really critical. The second piece is really, so once you've found the patient, you've come up with your targeted list, then you have to be able to figure out how do you render that information in bite-sized chunks that are digestible without creating alert fatigue for the provider or the care team or care coordinator to be able to act upon it in a way where you're not just dialing for dollars to try to bring in patients with a low conversion rate, but you're affecting an outcome while the patient is actually at the doctor, but balance that the provider's already getting inundated with alerts, and do it in a way where you're able to focus the time and attention that they have on the right areas. So once you've done that, then you've delivered the targeted interventions. Now you have to document in a way that you have compliant documentation with the right level of specificity, and you have to code it, because if it's not coded and doesn't get on the claim, then you're not going to get reimbursed appropriately. You may be subject to audit, you may be subject to just low levels of reimbursement that you're not able to take credit and get paid for what you've actually done. And so with ambulatory really at the tipping point now, where more and more care is provided in that setting, being able to make sure that there's less revenue leakage is really important in terms of being able to ensure the financial health of the provider organization. So as we think about this, what gets me really excited, and particularly in my role of Nuance, of thinking about new solutions and helping us bring world-class solutions to market to help our clients, is that we have an incredible base to draw from. 72% of provider organizations in the U.S. use one or more Nuance products. And so being able to leverage that and all the experiences we've had in there positions us in a really unique position and to deliver just-in-time information to the key healthcare stakeholders, whether it's the provider, the patient, members of the care team, or other stakeholders, maybe the payer, or other folks that are coordinating care on behalf of the patient. Our solutions, as an example, our physician-facing solutions are used by over 400,000 physicians. So that in-workflow expertise is really helpful to know how to deliver those bite-sized chunks without creating alert fatigue to the provider. And being in workflow, I can share both from my experience at Nuance, but also in prior experience, being in workflow is so critical to be able to make sure you're not having to go into another portal, you're not having to download a report beforehand, but the information is delivered in a way where it's actionable right to the appropriate member of the care team to be able to act upon it. And so this is one of those areas that we really focus on as an organization, and that's what makes this so exciting, is the unique way to be able to touch so many patients and physicians in a manner that really matters to deliver value and impact, both from a clinical perspective as well as from a financial perspective. So when we think about our solutions and how we are delivering them in the market and why we've thought about approaching it this way, it's really about integrating the key healthcare specialists in the right roles to be able to deliver value to the provider organization and the patient. When we think about this, I use the word patient, but I sometimes cringe when I use the word patient because nobody wants to be a patient. They're really a member of a plan, and when we think about it in the context of risk adjustment and risk-bearing entities, that patient is also a member in a program, and being able to engage them in a way proactively is really the way that you create loyalty over time. And so it's really about taking those stakeholders, and when you find that patient that needs additional care and attention, it's about being able to identify and work through the mechanisms you have in place to be able to bring them in, do the reviews of the charts to make sure you're focused on the right things, make sure you're not just checking the box on quality to avoid a penalty, but you're really closing gaps in care. And an example I like to use here is a case where a patient had a CT. Well, that's great. They went in, the order was completed, the patient had the CT exam. Well, what happens when there's an abnormal result? How do you close the loop? So as we continue going through the materials, what you'll see is we're taking a very innovative way in terms of approach to think about quality, where it's really true quality of being able to affect the clinical experience and the health outcomes for the patient, to be able to close the gap in care. And so we're really spending a lot of time on that. And we're approaching this programmatically to be able to ensure appropriate reimbursement and make sure that as the provider is documenting, that we automate as much as possible, because what we don't want to do for the industry is add additional steps that creates additional work. We want to take out steps and use the intelligence of our solution to automate, to drive the results that everybody wants to see, to bend the cost curve and improve quality and outcomes. So this is really what makes it cool, how it works. So this is one approach, and I'll talk about another approach in a minute of how we enable the solution. So our technology every single day is continuously running. It scans the charts. It uses natural language processing, artificial intelligence. It can take documents that are scanned in. If it's a system that has lots of historical paper records, maybe you're still going through an EHR implementation, you haven't quite gotten all the practices in, or you have some practices you've recently acquired and you haven't gotten them all on a common EHR. We have OCR software that enables bringing in records. If you're already on, say, an Epic or another system, we have the ability to pull in those records, apply our analytics and heuristics and models to be able to identify those patients with the greatest opportunity by group, by physician, by panel type, looking at whether it's a Medicare Advantage member in an MSSP-ACO, whether it's a provider-owned MA plan, whether it's commercial risk, or other types of risk methodologies that may be applied. So we have the ability to apply the right rules to be able to find the patients. We do that through an automated chart review. Then what often happens is you'll find, say, it's Aunt Sally, she's 65 years old, she's a Medicare Advantage member participating in an MSSP-ACO, and it's January or February, so it's early in the year, and we found that historically she comes in 6-7 times a year. While Dr. Jones may be a busy primary care doctor that sees her regularly, and the technology is smart enough to recognize that we don't have to present all the opportunities to Dr. Jones at once. We can prioritize, and the technology prioritizes the opportunities to focus on the ones that are most impactful for that visit, focusing on patient safety, of course, first, but then looking at other opportunities and staging them as appropriate. And that's really key to be able to make sure that there is a sequenced approach to maximize the outcome, because if you throw everything in the kitchen sink at the provider or the care team, they'll time out and they'll reject it. And so we'll talk more in a few minutes about our approaches to help ensure the alignment of the care team, but the prioritization capability is really key to make sure it's immediate actionable and it's most appropriate for that point in time. So the advice has been prioritized and presented. Then as the physician or member of the care team is going through the process, as the documentation is created, we have additional assistant that will help clarify the documentation working with the provider. We will help automate the coding process. There are a number of organizations that certainly have their own coders, but one thing that we found through much of our research is that HCC coding is not always the same as traditional coding, and what you look for and the lens that folks are looking at as they're doing traditional coding often makes them miss things that would be HCCs. And so our software enables to ensure appropriate automated documentation, plus can provide a cost savings opportunity by getting more done upfront while the patient is there. Also helps avoid compliance challenges as a result to enable appropriate documentation and reduce costs also by needing fewer coders to do the work. With all this, technology is great, but if you don't have the reporting tools to then be able to identify where is the opportunity and more importantly, how do I manage and control what I have going on within my practice or my groups or within a health system in the ambulatory setting, then oftentimes the performance will slide. And so we provide the reporting tools to be able to view that and be able to manage it programmatically. Now, this followed initially through an approach using an upcoming appointment when you have a patient scheduled to come in. The technology very much also works to be able to discover patients that should be brought in and where you would want to have a care coordinator perhaps reach out and work with the patient to bring them into the appropriate doctor and make sure that they're getting the care that's needed to close gaps. So when we think about the overall solution and how we're going to bring these capabilities to provider organizations, there's really three pillars of the solution. The first is really fundamentally risk adjustment, where we have the ability to look for, using inferential logic, to be able to identify new opportunities. For example, a patient has elevated hemoglobin A1C levels for the last 3 months and has a insulin-based drug on their med list, but for whatever reason, maybe they're a new patient or whatever, that they have not been identified, there's not a diagnosis, and there's not a code on a claim to indicate that they're a diabetic. Well, the technology actually can identify that, score it, and then help the care team manage that. We also can look back at historical claims in addition to the medical records itself and identify patients that had a condition, say diabetes last year, where it's on a claim and there's no cure, so they likely still have it. And you want to make sure that you're continuing to monitor and manage that and get credit from a risk adjustment perspective. Because if it's not documented this year, that's great that it was done last year, but that often means you're not managing the patient as tightly. And equally as important, if it's not documented, you're not getting financial credit for perhaps even work you are doing to take care of that patient. We also have, as we're implementing the solution in organizations, a coding workspace that allows you to, you don't have to just trust the technology and what it does. You can drill in and see in great specificity the opportunities from the historical encounters and what were the triggers that led the technology to include, more likely than not, that this patient has this condition and therefore should have certain types of care provided. So that's the first pillar. The second pillar is really about quality and specificity. So in workflow, making sure that you know what the quality opportunities that you need to address, and making sure you get down to the right level of ICD down specificity to make sure that you have accurate and complete documentation. With all this, we have also wrapped it into terms of the pillars of the solution: safety and compliance and point of decision messaging, really being able to pull in other stakeholders over time and be able to deliver targeted messaging to be able to affect the right outcomes depending on different points in the workflow. And so as we are bringing this solution to market and really trying to change the game in an environment with high volumes and limited time for providers and care teams and even patients or members, we really wanted to make sure that we're building something that's not just a point solution, but really is a platform that scales and grows with organizations as we evolve in a value-based care world. So oftentimes when we talk about solutions, it's important to have context of what's possible, what's achievable. So with one large health system using aspects of the technology that we just discussed, fairly substantial results were achievable. This reflects a 3-month study with a productivity improvement of over 400% relative to their historical very manual approach, administrative savings in excess of $10 million, increased reimbursement of over $3 million. Again, this was just a 3-month period, and a very substantial ROI. That's pretty incredible when you think about this. And when you think about whether you're looking at applying, in some organizations, significant manual effort, one of the challenges is that the more labor applied, the less benefit you get, and there's often opportunities where you miss being able to achieve the results that you so desire. With the technology, one of the greatest benefits we've heard from clients that have shown interest in this is really the standardization and the consistency, and that really also helps drive compliance with audit and really making sure that it's not gaming the system, but it's really providing better care, and the byproduct is higher reimbursement in some cases. But it's really about achieving accurate and complete reimbursement while primarily enabling better care. And so this is a consistent theme, and it's really one of the reasons why we're so proud of bringing this to market and enabling the beginning of a multi-year transformation in the industry around accepting risk and moving from a patient-centric model more to a member-centric model of treating the member holistically and thinking about it over the longevity of providing care to that patient and building a relationship that's lasting and engendering loyalty in the process to affect greater satisfaction and better care. So with that, I would love to answer any questions that people have, anything that you'd like to go back and get clarification. And this is so exciting for us at Nuance to be leading the way here, and would love to open it up to discussion.
Thanks, Jeremiah. I'll go through a number of the questions that have come in, and folks, please continue to ask questions as we go through the presentation. So Jeremiah, the first one for you is, how deep does the chart review go? Will it pick up things in Care Everywhere from Epic scanned documents? For example, will it pick up diabetic retinopathy from a scanned ophthalmology note?
So yes, the technology will go as deep as you want to apply it. You can apply it to as many data sources as you bring in. If it's in the medical record, it can import it and bring it in. It's extremely fast in processing the data, and it has the ability to present the information so you see exactly what is pulled in, what is relevant. In the chart reviewer, if you want to see exactly what it's referencing, it highlights the items, and it really is as granular as you can possibly get in terms of going down to the 0-foot level within the chart. Within other population health systems, whether it's Epic or CERN or other systems, you can pull in data feeds and have it processed for a richer level of processing. And you can also pull in labs, radiology reports, and other documentation sources to really have a holistic composite picture of the patient, as well as look at it not just at the patient view, but at the practice view, at the physician view. You can see how, based off of the charts, real data, the facts, how one group of physicians or one practice is doing versus another. You compare centers of excellence maybe within a health system ambulatory setting to others, and really use that to be able to benchmark even your internal performance.
Thanks. I'll add to that just briefly, maybe talk a little bit about how comprehensive the engine and the medical taxonomy and the rules and guidance behind that is, how carefully we've brought that together to make sure that we only provide high confidence information to the population health and physicians who are looking at this data. It probably would help to just provide a little bit of background on why we chose to do it that way.
Yeah, absolutely. So there's two really fundamental things when you think about what makes our approach so different. So the NLP technology and the analytics component of the solution has 15 years of expert scientists, PhD mathematicians, product management experts that are really focused. It's been developed over the years and in a manner that allows for mining records with a very clinical focus. There are a number of other NLP technologies on the market that made their way into healthcare, but were not purpose-built with an underlying taxonomy with over 2 million terms. So we've brought some incredible power as we've knitted together our solution to be able to bring a truly integrated solution that's comprehensive. Then with our technology, because it's using a combination of deterministic and probabilistic or statistical techniques, there is a confidence score associated with every single opportunity. You don't have to worry about seeing all of that. It can be exposed, but the technology is being able to identify the value of each opportunity relative to the probabilistic value, and then based off of criteria for your individual system, your group, your practice, down to even potentially the physician level. You can set preferences that affect what confidence intervals are appropriate for what type of provider and what type of opportunities even within that you want to share. So for example, a primary care physician, you may show a broader set, but a rheumatologist or a psychiatrist or somebody else may have a more limited set of opportunities that are most especially applicable to their specialty of practice.
Okay, thanks very much. Let's talk a little bit more about what the population health specialist is seeing and then how that translates into what's presented to the physician. So when it looks for the missing HCC codes, does it also look to see if there's a higher HCC that could be coded instead? For example, uncomplicated diabetes mellitus versus diabetes mellitus with nephropathy.
Yeah, so that's a great question. So it's looking at accomplishing the highest level of specificity based off the information that's shown, and if there are different additional axes that could be brought in based off of clarifying the record, the population health solution will identify that there's an opportunity. Then as the population health coordinator, if it's not an opportunity that's at the high enough threshold to automatically go to the physician, if it's manually reviewed, then that will transition if it meets the threshold of being presented to either another member of the care team or to the physician to be addressed in their workflow. So that one of the key things that's so critical as it relates to HCCs and the documentation, both for providing quality care as well as compliant coding and reimbursement, is to make sure that you're doing this while the patient is actually present. Because if you're doing it after the fact and you're coding to a higher level of specificity than what was actually reviewed at the time the care was provided, then there are organizational risks associated with audit and compliance. And so it's really important to have the upfront analytics to find the opportunities and then to get the specificity at the time care is rendered to the patient to be able to ensure appropriate reimbursement.
Thanks, Jeremiah. I'm going to switch gears a little bit and ask you about how it's presented to the provider themselves. So what would it look like in the EHR to a provider, whether it's an Epic or Cerner or what have you? And along with that, does that provider facing clinical guidance use Nuance's Dragon Medical Advisor technology?
So that's a great question. So the way the solution works is it's an overlay on the EHR with the ability to transmit information both ways. So it can push data back into the EHR and it can receive data in the EHR. It's continuously monitoring as the physician or another member of the care team is typing, it's actually in real time updating. So if there's an opportunity in the little prompt that shows, say this patient had historically had diabetes documented and it's a new year, if the physician naturally addressed it, that's going to drop off and the physician's not going to get bugged. But as the physician is documenting, if something else pops up or there's some indications that the patient perhaps has a certain condition and the confidence score behind the scenes is high enough, then that's going to prompt, and the physician will have an opportunity to address that opportunity and close the gap and get the support of clarifications in workflow to make sure that the specificity is accurate and gaps in care are addressed to be able to maximize the limited time the physician has with the patient to improve the health outcome and ensure full reimbursement.
Okay, very good. Thank you. Let's switch again. Let's talk a little bit about the return on investment and the case study that you mentioned. So the first question around that is the 26-to-1 return on investment inclusive of both improved reimbursement and administrative savings? If you could explain that a little bit further.
Yeah, so for some of these, there's some sensitivity around specific client organizations, but it's a combination of improved reimbursement by being able to find more patients that have conditions that otherwise would not be properly documented. It's bringing in more patients, so the patient acquisition side in terms of bringing in more patients for the care that they need. And then it's also some cost takeout by being more efficient on the coding side with automation, basically do more of the coding in an automated manner and having less duplication where you have perhaps traditional coders and HCC coders looking at the same record and being able to do things faster and move the throughput through the system.
Okay, thanks. So that would help lend some explanation around also the 10 million in administrative savings that was shared as part of that case study as well, correct?
Yeah, absolutely. So that's a large organization over a 3-month period, and it really reflects the ability to take out quite a number of manual process and really be able to support a much higher volume. There's some organizations that have very manual processes where they'll take and transplant ambulatory or acute CDI professionals into the ambulatory setting. The challenge is, from a scale perspective, that's limited in the ability to do that in a practical sense, just given cost constraints. Plus, when you think about the flow and the volume going through, when you're able to do more and more of this with technology and the automation, as you can imagine, when you have a few 100,000 people going through the door of a large health system a year, the scale associated with that can be huge. And to be able to drive the automation, you're able to reach more at a much lower cost and drive greater value through a more targeted interventions.
So that's a great question, actually, Jeremiah. Thanks. Some folks are asking, I think it might be a good time to investigate whether or not we've looked at blockchain technology and where there's potential for a scale here, if you have some opinions on that.
So blockchain is interesting. There's quite a bit of buzz around it. It's a really good technology in terms of being able to keep a journal entry over time, of being able to track and have some referential integrity into data sources. It may be something that finds its way more deeply entrenched in healthcare over time. One of the things, though, that we were looking at as two of the primary factors as we were architecting our solution is really about being able to pull in the data sources cheaply and effectively from multiple sources, whether the EHR system, lab systems, population health systems, etc. And then two, be able to present the information in the workflow for the provider. So while I wouldn't rule out exploring blockchain further in the future, I think what we were really emphasizing is how to simplify the experience for the provider organization, for the member and the other stakeholders. And so I think we're looking at blockchain from the perspective organizational and from a monitoring perspective, at least for this particular solution, we're staying vigilant, but right now it's less applicable. It may be more applicable in other areas that we're focusing on, but here we're really trying to keep the cost down and really focus on the automation aspects and the precision in targeting the interventions and the documentation and coding. And we've been really focused on making sure the cost structure of the solution works, because when you look at MIPS and MACRA and value-based care, the benefits ease in gradually. And so we had to be really cost conscious when we were designing the solution to make sure that we didn't over-engineer it in the process, where we showed up with a Ferrari when the industry needed something more like an Audi.
Thanks. So actually that leads into the next set of questioning, which I think will help folks understand what it takes today and what our current plans are. The first question around that is, what's the system IT requirement from an implementation and support standpoint, not necessarily from technology, but from the people aspect? What kind of resources are we looking at to implement this? And the person asking the question has an Epic system in place.
So that's a great question. So I'm going to take a step back before I answer that question and talk about how to bring the organization or organizations in general together, because as we think about the transformation of taking risk, it's really a huge adjustment for the industry. And it's not just about throwing in some technology and plug and pray. It's really about an organizational philosophy of how do we deliver value and do it in a way that may be a little bit different than historical approaches to get the cost structure right and get the focus right to be able to maximize the benefits. So as we roll out these solutions to clients, we very often start with physician alignment strategies and organizational alignment strategies, because you have to make sure that everybody's rowing in the same direction. You've got the right incentives in place to drive value and impact. In some cases, even if you're taking less risk up front, but you recognize with MIPS and MACRA and the gradual rollout, and it perhaps maybe looking organizationally at having your own health plan or getting involved in an ACO, whether it's a commercial or MSSP ACO, that even you have to put the training wheels on first, and you have to give it a ride around the block and get going before you dive deep in. And so really understanding what it takes to be a risk organization. Certainly there are a number that are doing that, but as an industry, we are still early on, and so we have some really great best practices from client experiences that we find really move the needle on getting the alignment, maximizing the outcomes. From a implementation standpoint, I'll break it out into the different pieces. It's a phased approach to make it digestible. We start with making sure we have the appropriate education, the physician alignment and organization alignment strategies, best practices and approaches socialized and implemented. We work with the organization to implement the population health analytics very early on, so you can see what patterns and things are going on. We see from clients often that what is thought to exist in the organization, when you layer on the incremental power of the NLP and the analytics that we offer, they find a lot more, and it really evolves the thinking of how they want to approach risk and even how they manage their patient populations, whether it's risk-based or not. And then from there, we layer in technology like our Dragon solutions. Although if you're using something else, we'd love to convert you, but if you're using something else, we can still coexist alongside without interfering and be able to present the in-workflow alerts at the right time. And so we go through an extensive effort to make sure the physicians and the other member of the care team that would be getting those alerts understand how they work. We navigate through the process of configuring so that you get the right type of prompts at the right time to meet your personalized needs in the appropriate context. And then we put together an ongoing monitoring program with the reporting tools that I mentioned earlier to make sure that the program's on track. We do monthly and quarterly health checks to make sure that we're engaged as a partner in your success. We're not dropping off technology and leaving. We want to make sure the results are there. And from my experience, I'll just share personally, the financial results to me are important as a byproduct, but to me what's exciting and what I think gets our clients excited about the solution is the ability to drive quality that has the effect of being able to then get the improved reimbursement through better clinical practices and really elevating the performance and using the intelligence and automation to amplify the human experience and do this in a way, and this is one of the things that we really focus on heavily in the training and the education and the physician alignment, is we will take out steps from your process. We will make the workday for the physician and member of the care team easier. And so that's where when you see the technology, that we get very high conversion rates in terms of what is presented and the accuracy of the opportunities because of how long the NLP has been developed, the many different data sources, in fact, behind the scenes used to be able to tune and refine it. The system is a true always learning system, so it's continuously getting smarter. The AI in there is so powerful that over time, the precision is getting better, the recall is getting better of the results. And so it's really a system that learns and evolves with our individual clients and then with our overall base that is using the solution over time.
Thanks, Jeremiah. I think just to add to that quickly, someone asked if this is a computer-assisted physician, CAPD solution. Yes, it is, and I think you can tell from the breadth of the response that Jeremiah just provided us that it's so much more than that. It's so much more than just physician-facing. It's about connecting the care team and providing a better experience for the members in the healthcare community. I think
Karen,
along those lines too. Oh, sure. No, go ahead.
Karen, I really appreciate you emphasizing that because that really is key. It's really an intervention management platform with the ability to get the documentation right and do it because it's a CAPD solution. In most cases, the first time, get the compliant coding done and be able to do that and really do it in the first pass to cut out rework, administrative, additional steps, costs, and aggravation that leads to burnout for the many stakeholders involved.
Thanks. I think there's another question here that I think is related to that. It's more tactical, but it's really important. In that, as a provider is presented guidance, can they bypass an alert or a prompt, and is there a way to monitor that? And from my experience working with CAPD products over the years and working with physician-facing products, you can certainly make prompts required, but in terms of physician adoption and engagement with that solution, anytime you put a hard stop in, it's going to be difficult for them to work within that workflow. Usually it's better to educate and provide a physician an option to see it, and if they choose not to respond, yes, there is a way to monitor that so that you can go back and look and identify if there are issues with the question or if you want to provide additional education or guidance around how to respond to that question so that it's more of a collaborative implementation rather than a hard stop that they have to deal with that may interrupt their workflow. So Jeremiah, I don't know if you want to add to that a little bit.
I think you covered it really well. What I would say is two things. One, it's really important this is a collaborative process, and getting the incentive alignment with the physician to drive the outcomes that are desired. Making sure there's skin in the game for the providers and the member of care team in the process is really key to get the outcomes, but doing it in a way that's accommodative, and that's why we have very granular levels of configuration is important to make sure we're getting the right messages to the right stakeholders and people involved in the process. But there are going to be times where you have a physician that's seeing 30 patients in a day and they just don't have the time. And it's not to say the physician's a bad physician and they don't mean well, but there are bandwidth constraints, and that's where the reports and the ongoing monitoring and the health checks that we routinely do for our clients with these types of programs really are important, because we can help you identify where there are opportunities that you may say, okay, this patient has some specialty conditions or needs additional care, and we need to rebalance the workflow. We may need to consider changing a PCP to a different one and rebalance who the patients are seeing. There's a number of techniques that can be applied, and these, of course, are at the discretion of the organization and certainly can involve the patient to the extent the organization wants to have them involved in that process. But we really take a very holistic member, patient, and provider organization-centric view to make sure we're getting you the best outcome. It's not about trying to optimize just one metric over another. It's really trying to take a programmatic approach to deliver the best outcome.
And about how long does our implementation process take? And is there any guidance for how much IT effort needs to be budgeted and accounted for when preparing for taking on an implementation like this?
So that's a great question. So the solutions are that are part of this are cloud-based. So that reduces the implementation overhead. There is interface work that needs to be done to connect systems to be able to get the feeds. Then from a general timing perspective, I would really defer that question to a consultation with our implementation services team at the right juncture, because it varies by client. It depends on which EHRs are brought in first, second, third, and so on. And it really depends on what population you're focusing on, if there's geographic concentration, or if there's geographic fragmentation. So there's a number of factors. So I wouldn't want to create an expectation one way or another with incomplete information. I would say there are components that can get up really, really quick and get value as additional ones are incrementally rolled in. But generally, we can move relatively quick, but we like to meet our clients where they are at the pace that they can operate in. So that really is why that consultative discussion around the most effective rollout plan really is so important to deliver value and be able to operate at the pace the organization is ready to proceed at.
Sure, that makes sense. Here's an interesting question. Let's talk about the impact on telemedicine and where we see that playing a role here.
Yeah, so that is a great question, because there are certain aspects of outreach that can be used to build loyalty with patients, provide care at lower cost, track patients based off of certain conditions to be able to reduce or mitigate the risk of the exacerbation of conditions. So it certainly plays an integral role, and this tool may be an asset that an organization wants to use to be able to focus in on what patients would be most suitable for a certain type of program, and really look at both the clinical and financial aspects of it. And the nice thing about the tools, while I personally like to focus more on the quality, the tools do give you an indication of the potential financial impact. So just being practical, there are organizations that operate from a perspective that just to keep the doors open, you really have to be very financially minded, and that's fine. And so you can use this to be able to find those patients where there's the greatest opportunity to move the needle from a financial perspective, which often also has a high clinical value impact too, and be able to use that to target and then use that to pull in telemedicine assets as well to focus care.
And then thinking about the continuum of care and the different members and components of the healthcare system, how do we see this working to coordinate with an ambulatory surgery center and other outpatient venues like that?
So that's a great question. So one, if we get the data feeds and we have the record, the system will review. For ambulatory surgical centers, we actually have some additional solutions also very focused on them to help providers document using a surgical CAPD solution as an example, to be able to provide care and documentation and have the level of standardization from a compliance, from an optimized workflow perspective, from a reimbursement standpoint, and from a patient transparency perspective and coordination of care. That isn't it great to be able to get documentation right the first time, and by the time the patient leaves, just as an example, if they were having a colonoscopy, that they leave the visit or the procedure with an actual copy of the report, and the provider already has it documented before they leave the building, and it's already in the EHR with the full study. So we have some other tools beyond the quality and risk adjustment solution that really focus on surgical documentation, both for adult medicine as well as pediatrics in the surgical and ambulatory surgical center area.
Thanks, Jeremiah. So that's brought us about to the end of the questions. So thanks again for spending time with us. If you have additional questions for us, we'd be happy to talk with you. You can contact us through the information that you see here on the screen, or Emma can help you get in contact with us after the event. So with that, Jeremiah, do you have any final comments? Otherwise, we can let Emma close out for us.
My closing remarks are really appreciate everybody's time, interest as the market continues to evolve. We would be more than happy to provide deeper in-depth discussions around our solutions and how it may fit for your organization, your needs. And certainly you can see my contact information as well as our Clintegrity CDI at nuance.com. Email on the last slide of the deck for further inquiry if you have questions or would like to discuss any of the topics we've covered today in more detail.
Wonderful. Well, thank you so much, Jeremiah and Karen, for just that fantastic presentation and discussion. We also want to thank all of our audience members for joining us today, and we hope to see you for future webinars. Have a great afternoon.